Hello, everybody. It's GYN Garage time. My name's Ed Pavlik, and I'm in Lexington, Kentucky on the 30th day of the government shutdown. Phew, that's been a long time. The weather here is cool, and we probably have a future of freezing rain in the pumpkin patch. Frank, I've been watching the World Series where the Toronto Blue Jays are a game away from making it more of a world event, but they've shown Prince Harry and Meghan at the series. Is there much interest in the UK?
In so the Blue Jays, is that hockey or is that football? I
This
don't
is,
know.
this is baseball, Frank.
Baseball. Oh, that one. Well, you have to remember that, of course, we invented baseball. We called it rounders, but we actually invented the damn game. I don't think, to be honest, American football is much more popular in the UK than baseball is. There's no doubt about that. There's quite a fan base, and as you probably know, American football teams do come over to the UK and play various bits of whatever it is you lot call it. I don't think baseball really has the same cachet. Um, the problem with a lot of American sports is that us British don't understand the rules. That's it. You may worry about the offside rule in soccer, or leg before wicket in cricket, but we haven't got a clue about half the rules. Why some people wander on and wander off again, and what a touch a down and fly. We don't really know that, but there certainly is a fan base in American football. And just as importantly, there was a big sumo wrestling championship in the Albert Hall for 4 days in London last week. And it was, I mean, the Royal Albert Hall holds many, many thousands of people, and the tickets were sold out every day. It was a 4 day event of these very large Japanese people throwing each other out of a ring, but it's very, very popular.
Well, I'll be darned. Well, today we're going to consider the question, is survival after fertility sparing surgery equivalent to survival after non-sparing surgery? Answer to this question is approached for both cervical and endometrial cancers by two papers. The first is titled Survival After Fertility Sparing Surgery for Early Stage Cervical Cancer Compared with Non-Sparing Surgery, a nationwide comparative study. And the second is titled Survival After Fertility Preserving Hormonal Therapy versus Hysterectomy for Early Stage Endometrial Cancer. The first paper was recently published in the Journal of Clinical Oncology, Oncology Practice in September, while the second was published in JAMA Oncology in early October. These works investigate if survival is affected by choosing fertility-preserving surgery. So what we have here is two different papers, two different cancers, and really two different fertility preserving surgeries compared to a hysterectomy standard. With that in mind, let me take you to the first paper. And that paper is the one that has to do with the cervix. And it's really quite simple. And there's a lot to be said about simplicity. But really, when they looked at a group of people from across the Netherlands, they came up with 1,500 people. 482 were in the fertility sparing group. The others were in the hysterectomy group, 964. And what they saw when they finished the study and it was a retrospective study that took place over 2020, 2022, for women up to 45, 18 to 45. Median follow-up was 9 years roughly. The minimum was 15 months. So now this creates really a difference in how you calculate the Kaplan-Meier survival. But if you look at just the recurrence, it was higher in the fertility sparing surgery group. It was 7.1%. And it meant that recurrence had a hazard ratio of 2.2. The hysterectomy group basically had a recurrence rate of 3.6%. Now, when you do the odds ratio for survival, for overall survival, basically you find out that that is 1.06, which is leading to their conclusion that there is no difference between fertility sparing surgery for women under 45 years of age. And because of that, it shouldn't be unrecognized as a possibility. The idea though I present here is with this cancer, have you followed recurrence and survival long enough? Now, the second paper, the other thing I'll point out about this paper is there's a problem really in figure 2 with regard to the fact that recurrence was supposed to be part of panel B. They put it in panel A, and overall survival was supposed to be in panel A, but they put it in panel B. It led to me in this particular presentation to sort of question how many times the paper was really proofed. The other problem was that they labeled the patients alive on what appears to be a Kaplan-Meier survival analysis, and the Kaplan-Meier really measures the probability of survival at each step, not patients alive normalized to the initial group. Furthermore, in this paper, when I looked at, and I think I have it right here, yes, I do. When I looked at what's boxed in green versus boxed in black, surgery versus fertility sparing, there does seem to be a difference. So, to me, basically, probably illegitimately using someone else's numbers that they've published. But as you can see, we end up going down to 48% here, and we go down to 35% less over, which is a lesser overall survival. And the same thing is true about recurrence-free, which is quite different. It goes down to below 20% from 55 for the surgical procedure alone. So, what I have to say about this is that probably they have come to the right answer. I'm not quite sure that the paper was really scrutinized by the authors or by the reviewers the way it should be. Now, in the other paper, the endometrial cancer paper, they did one additional thing. They dichotomized the study population, and it was quite a much bigger study population, almost 16,000 people. And they basically broke it down into young people and older people. The older people were 40 to 49 years of age. Younger people were under 40. Overall in the group, the 5-year survival, which might be, inappropriately short, it could be said to be about the same. So, but what if they really pointed out? They pointed out as you let people go longer in your surveillance, that there is a hazards ratio problem of death, about almost 5 in the fertility sparing group, which does not occur in the hysterectomy group. Now, the 10-year survival, the difference is almost 20%. About 18% or 17% is shown here in the bottom line of the table. So there is a risk. So I think basically young women who are considering fertility sparing surgery, which has basically a big hormonal component, should be aware that they may have their recurrence and that recurrence leading to a mortality before the child is 10 or 15 years old. So I think that's the reality from this data. Overall, the paper presents the idea that for 5-year survival, there is no risk between the two approaches of fertility sparing or hysterectomy. So I think these are two different bends on the same problem. If you're going to want children, you better want them early, and if you have either cervical or endometrial cancer, because your chances seem to be the best of escaping a mortality due to either one of these at a young age. Frank, what do you think?
Yes, I picked up on that. I think that how many surgeons, gynae-oncologists or gynecologists for that matter, are aware of these data. Clearly, the idea of fertility sparing surgery is talked about a lot. But I think these data just show the risk that these women are taking. And I'm not sure, as you said, that the 5-year follow-up is appropriate. I think it should be much longer than that. but you have the possibility, as you've mentioned, of a woman. And also the implication, of course, is that they get pregnant as soon as they've had their fertility sparing surgery, which may or may not be the case. We know that cone biopsy, radical pelvic surgery does interfere with childbearing. So they don't necessarily get pregnant the day after they've had their surgery. So there
Sure.
could be a couple of years before they even conceive. And if their risk of dying of the disease coming back is within 5 to 10 years, nearly 5 times higher, then these women, well, these children are going to be motherless by the time they're about 5 or 6. And I think those data are the important data that women should know. The other thing, of course, is that they're talking about hormonal therapy for endometrial cancer. Because of the data, we don't know what hormones are being offered, the duration, the type. We're also looking at the demographics. They haven't taken into account obesity and other factors that are associated with endometrial cancer. So I think in that particular paper, the endometrial one, there are quite a number of problems. But overall, I think women with pelvic cancer who suggested, well, you might get away with lesser surgery that maintains your fertility. I'm not so sure that that's something that should be necessarily emphasized without these data, without it. The other thing, of course, is they've chosen patients up to the age of 49 for fertility sparing surgery. Why would you want your fertility spared at the age of 48? For what reason? So I think the young ones may be slightly different, and that's obviously the risk occurs with the young ones as well. But I think both papers have selected, they've almost chosen the answers they wanted and then selected the data to go around it, I think. And that's the unfortunate bit of these two papers.
Yeah, I think the everything there that you've mentioned, I agree with. I'd also say is uh, when we talk about these cancers, we have a good estimate of what the lead time is on sort of cervical, but we don't on endometrial. And if the lead time from the initiating event or events, uh, are a factor here, probably some of the work that needs to be done is to sort of figure out what that is, because if the lead time is long enough, you need to know that because it probably gives you a protective advantage because things get spread out in time and you can have a procedure done and it can be sparing. But if the lead time is like 1 year or 2 years, that probably is a different
Mm, yeah. Yes, I think the ethics of, as you say, it's the lead time. How quickly does a very unusual hyperplasia or quite aggressive looking tumor, what is the lead time before it starts metastasizing or pretty slow? And also, of course, that if you've got an abnormal endometrium and you're treating it with hormones, the implication is that the hormone treatment treats the whole of the abnormal endometrium. Now, does that mean that a fertilized egg can implant anywhere into that endometrium because it's all normal again? Or is there a bit that if it happens to land on the bit where there's still quite a marked evidence of hyperplasia or some sort of atypia, then you won't conceive? And I think it's the paper's too fluffy, I think, to actually tell us very much about that, except the risk is there, and perhaps you should consider your health and the health of possibly your existing children over the fact that you might want to get pregnant again.
Absolutely. And those are heady decisions.
Oh, absolutely. Yes.
We appreciate that, although we're not people who have to consider it.
No, no.
Well, very good, Frank. We've done it again, and
Very again.
I want to continue doing it again, but it's nice being with you today.
Okie dokie. And I'll see you again just before Christmas. Oh no, the end of November. Yeah.
That's right. Sometime around what we call Thanksgiving. What do you all call that? Do you have a November
Uh,
holiday?
well, it's near my birthday. That's what I call it.
Okay. We'll be back for your birthday.
Okay.
You take care.
Cheerio.
Bye bye.